DocTalk, and I have Dr. Saracen, who is one of our medical leads here at Northwest Region Prehospital Care with us. We are going to be discussing the hot topic, no pun intended, of hypothermic arrests. In this video, we would like to talk about how hypothermia cardiac arrest is often treated as a fast-paced sprint, but the rules of the games do change with that type of cardiac arrest. Our goal today is not to memorize a checklist. It is to understand the physiology and the pause button that extreme cold does to the human body, and we're looking at that mummified heart and why it's resistant to the standards that we normally practice during cardiac arrest. So one of the big questions that we have from our medics, Dr. Saracen, is how can we tell if a patient is obviously dead versus a hypothermic arrest?
Great question. So identifying a hypothermic patient from an obviously dead patient in the pre-hospital setting is quite challenging because profound hypothermia can effectively mimic death, right? Especially stage 4 hypothermia, where the patient's core temperature is less than 24 degrees. In the pre-hospital setting, the guiding principle is the patient isn't dead until they're warm and dead. Some key indicators for distinguishing hypothermia versus death are pulse check time. So in a severely hypothermic patient, pulse and respirations may be present, but extremely faint. So you can allow for a full 60-second pause to check for a central pulse. The respiratory check, so similar to the pulse, breathing can be extremely slow or shallow. Observation for up to 60 seconds may be necessary. And then rigidity in pupil response. So don't rely on fixed dilated pupils or stiff, rigid limbs, stiffness that resembles rigor mortis to determine death, as these are common in reversible and severe hypothermia. Some signs of obvious death that are not hypothermia. So a patient is likely dead if they show signs of decapitation, truncal transection, decomposition, or dependent lividity. If they're frozen solid, so if the patient is frozen solid and you cannot perform chest compressions, it indicates irreversible death. And the circumstances, if the patient experienced a witnessed arrest, they may not be a candidate for resuscitation, unlike a person who becomes cold and then goes into arrest, which is highly reversible.
Okay, so when is a paramedic able to say a patient shouldn't be resuscitated then, and that they meet obvious death?
So as we talked about in the previous slide, the general principle that no one is dead until they're warm and dead comes from guidelines that were developed through the American Heart Association and the European Resuscitation Council. And this means that you need to be very cautious about terminating resuscitation in a hypothermic patient. So paramedics should only withhold resuscitation if there's clear, obvious death criteria, or if they're directed to cease resuscitation by a base hospital physician.
All right. So in the field, the H's and T's, which are reversible causes of arrest like hypothermia and toxins, they're often harder to diagnose because paramedics lack the immediate lab results that you guys might get in Emerge or imaging that's available. They have to rely entirely on physical assessment and history from family or scene observations and other settings of the hypothermic patient, and it adds an extra layer of challenge to our paramedics. So one of the comments that we frequently get asked is, why is hypothermia not spoken to in our directives or have its own directives within our ALS PCS?
So while it's no longer a standalone directive, hypothermia is still integrated into the current protocol. So within the medical cardiac arrest directive, the second clinical consideration specifically addresses known reversible causes of arrest unable to be addressed. And this category refers to the H's and T's, for which hypothermia is and remains one of the primary H's. So when arriving at a pre-hospital cardiac arrest, it's essential to consider the underlying etiology. What is the primary cause of this patient's arrest? Specifically, you should actively search for clinical evidence and environmental cues to support a differential diagnosis of hypothermia.
Excellent. That's great. So our with the AHA guidelines, they tell us to focus on more aggressive core rewarming as the primary therapeutic modality, and that hypothermia may not be responsive to cardiac medications and defibrillation. So let's have a little chat about that, as the concern regarding medication accumulation is a true thing that we should be concerned about, especially with our ACPs able to give medications during cardiac arrest. So what happens to these drugs once the patient is successfully rewarmed, and why is this not a focus in a hypothermic arrest?
That's a great question, and it's exactly the nuance that often gets missed in pre-hospital care. So what is meant by medication accumulation in hypothermic arrest? So in severe hypothermia, typically with core temps less than 30 degrees, drug metabolism and clearance are profoundly reduced due to mainly 4 factors. So there's decreased hepatic enzyme activity, there's decreased renal perfusion and excretion, there's decreased circulatory flow, especially in cardiac arrest, and decreased cellular uptake and receptor responsiveness. So when you give your standard ACLS drugs, specifically epi and amiodarone, they're not effectively metabolized when the core temp is less than 30 or distributed. They're not producing their intended physiologic effect. Instead, they just accumulate in the central circulation. And then paradoxically, what can happen when you bring them to hospital and you rewarm them, then the hepatic function starts to work again, the kidney starts to perfuse, and then you have all these drugs that were in your central circulation not being used that suddenly become pharmacologically active all at once. And this could lead to toxic drug levels, severe vasoconstriction from accumulated epi, malignant arrhythmias, refractory VFib, or electrical instability, and then potential contribution to post-ROSC cardiovascular collapse.
Wow, that's an interesting concept for our paramedics to remember when administering or thinking to administer those medications.
Yes.
So when we look at this slide that I'm showing right now, my interpretation would be that after I do my rhythm interpretation as a PCP or an ACP, I do that rhythm check. I decide if it's shockable or not shockable. So if it's pulseless VT or VF, I'm going to shock it. And if it's asystole or PEA, I'm obviously not going to shock that. But then I should be thinking about egress to the hospital and no further interventions then, or shocks. And that may be a concept that is somewhat hard for paramedics to wrap their minds around due to the fact that we see shockable rhythm, we would like to shock it. So why shouldn't we shock that heart?
So that's a great question, and it essentially refers back to the previous discussion regarding meds. So the one shock thing is okay, because if VFib or pulseless VTAC is present, the rhythm is still theoretically shockable. So early defib may work if the myocardium isn't too cold yet. So don't withhold the first shock. But then you should stop repeated shocks below 30, because below 30 degrees of core temperature, the myocardium becomes markedly less responsive to defibrillation. Cellular ion channels and conduction are profoundly impaired, and energy delivery is less likely to achieve organized depolarization. Repeated shocks have been shown to have very low success probability in the literature, and they may actually cause myocardial injury. And they also interrupt CPR unnecessarily while you're bringing the patient to hospital.
Okay. So it also states in the AHA guidelines that after the initial drug therapy of an ACP that would give epi or amnio, they should defer those treatments. And you did speak to how they can accumulate within the system in a hypothermic arrest. But should the ACPs prioritize that IV and drug interventions prior to thinking about leaving?
No, they should not delay transports to give epi and amiodarone first. So in hypothermic cardiac arrest, the whole goal is getting the patient to definitive rewarming facilities, not completing early ACLS drug sequences. So delaying IV and drugs is problematic because, as we said before, below 30, the myocardium is very poorly responsive to these drugs. Defibrillation success is low. So it really rarely changes outcome in the field. And the biggest goal for these patients is time to rewarming. That's the key modifiable factor in the care for these patients. So definitive care should be active core rewarming in the hospital setting, usually using warmed IV fluids, Bayer huggers, and then active core rewarming with either bilateral chest tubes or warmed Foley catheters, or even better, ECMO or dialysis. So every minute spent on scene, because we can't do that on scene, you're just kind of moving away towards definitive care for these patients.
Okay. Excellent. So the big wrap up for this and the key takeaways for managing this patient should be based on your BLS and ALS patient care standards is to manage your patient, stay in place, stabilize, but also be a load and go situation to get that rewarming going. So defibrillation, attempt one shock, but no further en route. Continue with your rhythm interpretations Q2 minutes just for information for the receiving facility. Withhold your medications until the temperature is above 30, and just that active rewarming with blankets, hot packs, etc., for en route to the hospital. And we need to remember that temperature is tissue for these arrest patients, and avoid that rough handling, as that could trigger potentially a VF for that patient. Insulate, stop the cooling process, try and get them warm, get them out of their wet clothing if you have to. And these patients do have the ability to survive neurologically after hours of CPR. So again, don't stop until they're warm, or until you're exhausted, obviously, depending on your transport times to your receiving facility. Any other items that we should worry about for our paramedics?
No, I think we addressed all the issues and concerns. I think the main point that you just gave us are really key in making sure that we provide good care to our hypothermic cardiac arrest patients. Thank you very much, Jocelyn.
Okay, thanks. Hope you guys enjoyed this recap of cardiac arrest in a hypothermic patient and how to manage it. And we'll hopefully see you on the next one.